Hello and welcome to this episode of The Heartbeats, the North East and North Cumbria Integrated Care Board's official podcast channel, giving you the latest news, innovations and health stories from across the region. Today, we're excited to discuss a critical topic, patient safety, with none other than Professor Sir Liam Donaldson. As one of the foremost experts in public health, Sir Liam has been at the forefront of patient safety globally. We will explore how health and care systems can protect patients, improve care standards, and foster a culture of safety in medicine. Sir Liam, welcome to the podcast today. Thank you for joining us. You've had a distinguished career in public health, including serving as the Chief Medical Officer for England. And I think what would be really interesting to know is, could you share what initially sparked your interest in patient safety, and how has this focus shaped your career?
Well, many years before I became Chief Medical Officer, I was appointed as a young regional medical officer to what was then the Northern Regional Health Authority, which roughly covers the boundaries of the present Integrated Care Board for North East and North Cumbria. And one of the first things that happened when I was in that post was I got a call one morning from one of the hospital administrators, as they were then called, to let me know that a patient in his hospital had died due to a mistake being made during the person's surgery. And so I asked him, well, what's going to happen? What sort of investigation are you doing? He said, well, I'd really wanted to let you know because I think there might be some adverse publicity, but the question of an investigation will be left to the coroner. And that was that, really. And then over the years, I started to get other calls like that, which were just to let me know. And I felt, well, just letting me know or letting the Regional Health Authority know isn't enough. We need to know why these things are happening. And indeed, the error that I was called about in 1986, where the patient died, could potentially still happen today if people weren't entirely vigilant. So it's really, I think, my interest in patient safety was sparked by hearing about individuals' adverse experience, sometimes experiencing harm, sometimes even dying, without the health service at the time starting to think, well, what caused this and how could we prevent it? And then finally, I started to talk to people in other fields of what was then called accidents and accident prevention. So people who looked at air crashes, or who were psychologists looking at the reasons for those, and found that they were deeply interested in what caused things to go wrong, and they were also deeply interested in finding solutions. And at that point, I concluded, well, the health service should be doing that. But it wasn't until I became Chief Medical Officer some 11 years later, from being that young regional medical officer, that I had the power to be able to do something about it.
Patient safety has been a central theme to your work, driven by a deep passion to protect patients from avoidable harm. And I guess, could you share the personal experiences and observations that you've had that has kind of fueled this passion for patient safety?
Well, those have come really from talking to patients and families who've experienced harm. And I did that when I was Chief Medical Officer. I remember one patient, a family member in particular, who came to see me. She was called Margaret Murphy, and she was from Ireland. And she'd been unable to get a meeting with the health minister in Ireland, and she knew about my work, she'd read about it, and she came to talk to me. And her son, Kevin, was a 21-year-old young man who had a condition that wasn't diagnosed properly. So he continued to have symptoms getting worse and worse and worse. And his mother, Margaret, used to go up to the hospital hospitals with him, and nobody could find out what was wrong. And indeed, some of the attitudes she encountered were very dismissive of their persistence as patients. And then it was a long and tragic story, but in the end, Kevin died of a preventable condition or a treatable condition. He had a very high calcium level and from a benign tumour, but it just wasn't found, and lived with a dangerously high level of calcium in his blood, which eventually killed him because nobody had done the necessary tests to find it. Margaret told me that she had unravelled the story of this herself. She'd asked for the medical record. She'd found a yellow post-it note where the correct results of the test were in the notes, but they were filed away and weren't noticed. She saw the occasions in different hospitals where the wrong diagnosis was being applied. People didn't think thoroughly enough about Kevin's case, didn't really centre on him as a patient who was still experiencing very serious symptoms. And Margaret is a person who has played a big role globally in patient safety because she's risen above the grief and tragedy of her own life and her family's life, and she's become an advocate for safer care. So she's told Kevin's story probably in hundreds of conferences around the world. People are very, very moved by the way she tells it, by the circumstances, by the sheer frustration of realizing that this was a condition that could have been prevented. So my passion was ignited by talking to Margaret. And then subsequently I've talked to a lot of patients and families in this country and also other parts of the world who've suffered similar experiences, often mothers who've lost children. Very tragic circumstances, almost all seen with the benefit of hindsight, were preventable events. But the key thing that's core to all of them is not really listening to the patient and families. And in a busy health system, that is unfortunately from time to time that happens, and it can have very tragic consequences.
In terms of your own contributions to patient safety, are there any sort of significant moments from your career history that you're particularly proud of, something that you've worked on that's had a real positive outcome in patient safety?
Well, I suppose in a big picture sense, and working as the country's chief medical officer does give you a big picture. It lets you see right across the whole country. When I was first appointed, I set out on a number of tasks that were in my mind. There isn't much of a job description for the chief medical officer. It's very broad and general. So in discussion with the government of the day, you work out what the priorities are. And I had an early priority to try and bring forward smoke-free public places, but that ended up a long battle. So it took several years to get to that point. But I also asked the ministers I was working for if I could look at the whole question of patient safety. It wasn't called that in those days. This would be about 1999, 2000. But I did get together a group of people, some experts within the NHS, doctors and nurses, and other experts from the field of accident prevention, including the head of safety for airline safety for British Airways, for example. And I set them up as a group and we worked together, and I produced a report called An Organisation with a Memory. And that was really the report that set up the entire patient safety programme in the NHS and drew attention to the problem that had not really been thought about before. So I was very proud with having produced that report. It's almost 25 years ago, so hopefully it has produced the degree of influence. And then I also made recommendations to the World Health Organization, because I was at the time represented the UK in a lot of international meetings when I was Chief Medical Officer, and they accepted the recommendation to give priority globally to patient safety. So that was another big picture change. So I think I was in, by that stage, having moved out of the region, I was in a position to instigate much bigger strategic actions, which then helped people working on the ground to do the more granular activities that are needed to actually prevent harm and put in place the measures to stop patients from suffering the impact of any error.
So this year's theme for World Patient Safety Day is improving diagnosis for patient safety. What, in your opinion, are the key systemic factors that lead to diagnosis errors, and how can health systems address these issues?
Well, unsafe care isn't common from any cause, but it isn't rare either. And if we look in this country, in this region, across the world, it's too high. So we've, over time, started to unpack the reasons why errors occur, as well as the main causes or areas of healthcare where those errors occur. Diagnostic error, giving the patient the wrong diagnosis, doesn't always lead to a harmful outcome. It can be spotted and corrected, but it sometimes can have very serious repercussions. And so diagnostic error is estimated by the World Health Organization to account for something like 15-16% of all the avoidable harm in healthcare that occurs anywhere in the world. So that's quite a big percentage. And the OECD, the Organization for Economic Development and Cooperation, which studies healthcare in lots of different countries, mainly in the developed countries, but it's found that something like 5% of the entire expenditure of all of those health systems in the field of looking after people with long-term conditions like diabetes, cancer, 5% of the entire health expenditure is because of diagnostic errors. So that's really, it's within the field of harm. It's a very, very significant element, and within the costs of, or avoidable costs of healthcare, it's a very big element as well.
So I guess additionally, how can health workers, patients and policymakers, how can that collaboration happen to enhance diagnostic safety and ensure that patients are fully engaged in the diagnosis process?
Okay, well, nobody sets out to make an error. And I think one of the difficulties in the past is that people are assumed to be possible of being perfect, which they're not. To err is human, as very commonly said, and that's the same in healthcare as it would be in any other field. And so we've tried to create a culture in dealing with patient safety where people are rarely blamed for making an error. It's the system around them that puts them in a position to make an error. There are rare cases where people are negligent or willfully misbehaving, but those cases are very rare. The majority of the errors that occur are genuine mistakes, but they're provoked by things like staff working in a very fast-moving, high-pressured environment, maybe having to use technology that they're not completely familiar with, maybe having a shortage of staff around them, not having the experience to cope when a senior member isn't present. All of those things contribute, and those are the things that we tend to refer to as the system. It's a technocratic word which people don't warm to, but it's really very, very important in patient safety because the two things come together. If you put a person, a doctor or a nurse or another health worker, within an environment, within a structured organization of providing healthcare, which is dysfunctional or weak or puts pressures on them, then they're more likely to make a mistake. It won't be their fault, but the patient will suffer as a result. So it's addressing those underlying factors, like ensuring that there's good teamwork, ensuring that staff have the education and training to be able to have the skills to diagnose patients well. It's giving information to patients because they have a part to play as well. And then I think the other area which is both interesting for those of us who study these things, but also a concern, is the extent to which technology will help to reduce diagnostic error and the extent to which it may introduce other risks. So, for example, we read in this region about some excellent work whereby artificial intelligence is being added to endoscopy procedures. So when somebody has a colonoscopy for looking to see if they have bowel cancer, the AI will be a second pair of eyes through the instrument, through the endoscopy, colonoscopy, and be able to enhance the skill of the surgeon who's doing the endoscopy. Now, most of them are very good at it, but it just gives that extra few percent of accuracy and reduces the opportunity for somebody to perhaps miss a bowel cancer that's present because it's so small. And then if that would be a classic example of a diagnostic error whereby then the patient might go on and get a more advanced form of cancer without it having been recognized. Most of those are spotted by the human eye at the moment, but building a machine element into it, if it's carefully designed, can enhance and reduce the chance of errors. So that's one thing, but then on the other side, technology is everywhere in healthcare, and different machines have different software, they have different calibration and so on. So if a nurse, for example, is moving from one hospital to another and having to set up a machine which delivers a drip and a drug of a particular dosage into a patient's system, then she needs to be aware of the different ways in which these machines operate. And that's another thing where, although those things have saved a lot of time and they've probably reduced some areas of risk of mistakes, you have to watch because there are potential dangers in other aspects to be compensated for.
Yeah. And that leads us on quite nicely too. So now, in this region, the regional quality strategy that I believe you're leading on aims to apply common standards across the region. How do you envision this strategy improving patient safety, and what challenges do you foresee in implementing these standards in the community?
Well, quite recently we've decided, with a population of 3 million, that we're actually bigger than about 30 small countries of the world. So we should be looking at this not by only looking at what happens at local level, but looking at the things we can do right across all of the organisations that provide health and care in the North East and North Cumbria. And so we're going to establish a patient safety centre, which will look at all of the things, both that go wrong, all of the incidents that occur and what we can learn from them, but also to pick up some of these common causes of avoidable harm, like diagnostic error, proactively before anything happens, and start to explore them and work out the reasons and the ways in which we can prevent them. So I think the answer to your question really is that we need to create a fresh focus where we bring in the best national expertise, and with my connections to the World Health Organization, the best international expertise.
I guess when you're developing these approaches, what sort of role does international evidence play in shaping these kind of policies?
Well, what I've found so far in my 20 years or so of helping the World Health Organization talking to a lot of people, looking at what happens in the country, how so much of the causation of harm is shared. Even if you go down to the level of individual patient stories, you can see the same thing went wrong in somebody's care in two places 3,000 miles apart, two places not just 3,000 miles apart, but 3 years apart in time. And so having an understanding of those common factors is a huge benefit to being able to look at ways to prevent key sources of harm, which, as I say, are not common, but they're too common than they should be.
As the World Health Organization Special Envoy for Patient Safety, how are you integrating your or integrating international best practice into the regional strategy? And what innovations that you've encountered are you most excited about pursuing for safer patient care?
Well, I will be involved in the launch of the World Health Organization's World Patient Safety Day, and as a result of that, I'll be in contact with people all over the world, the best experts, as well as the patients who've have suffered harm because of an error in their diagnosis. I'll be capturing that expertise, making sure that my colleagues in the Northeast and North Cumbria are aware of what's happening elsewhere. And that will be one of the tasks in the Patient Safety Centre, to bring international evidence into the picture.
Thank you for listening to this episode of The Heartbeats. You can stay up to date with all of our content by following the Northeast and North Cumbria Integrated Care Board's YouTube channel or Spotify channel. Stay tuned for the next episode.